We are so pleased and lucky to have a representative from Dignity Health. It's a very large health system on the West Coast, Katie Hesse, Director of Emergency Services, who provides support at the system office across their 29 hospitals. Just a little bit more about Katie Hesse. She is, as I said, the Director of Emergency Services at Dignity Health. She has had oversight of 37 emergency departments for the system, and that includes quality and safety metrics, new initiatives, review claims, and all of the goals established for the system every year. It's a big job. It's a big system. Katie, we're very, very excited to have you with us today, so welcome.
Thank you.
I also have with us in the audience, right here, actually, he's not in the audience, he's right sitting next to me, Dr. Bill Binder. He's an emergency medicine physician, and he is actually one of the primary content creators of all of our emergency medicine content. So welcome, Bill.
Thank you.
We're thinking you might be wondering some of these questions. How can we reduce variation and risk in the emergency department? How does GNOSIS measure individual and team proficiency? How does GNOSIS build high reliability and improve patient safety? And how does GNOSIS help improve triage accuracy and the speed to diagnosis? I'm going to spend a little bit of time just talking about GNOSIS and APS. We have two primary education solutions on the GNOSIS and Proficiency platforms. Proficiency is really our hiring and onboarding solution. You know, we're an innovative company, and we spend a lot of time trying to solve the biggest problems in healthcare. The nurse workforce and nurse turnover and bringing nurses to function faster are some of those problems where we're actually seeing improvement, and many of our clients are using that. If you're interested in that, please make sure you follow up with us. And then GNOSIS, of course, is our assessment-driven education solution, and we have education really in obstetrics and emergency medicine, and we'll be building out more content in med-surg in the future. So how does GNOSIS work? It's really a very innovative and a novel approach to education. We measure knowledge and judgment through a validated assessment. We do this on the OB side, we do this in the emergency medicine side, and we're primarily talking, and Katie will be talking about their efforts and work so far using the nurse triage program. Because it's assessment-based, we're measuring proficiency. Clinicians can actually test out of content, and they're testing into content. So they're only getting education on what they need based on their current level of proficiency. The next box, number 2, you see there is really all about maximizing learning. And so, again, you're getting prioritized education in red, yellow, and green. Green means you tested out of it. And, again, you're getting high fidelity, interactive education snacks from 2 to 8 minutes, and it's all personalized based on the individual's needs from their assessment results. And then, of course, you see mitigates risk in the third box, which is because we're assessment-based and assessment-driven, we're able to derive analytics from every single user that really helps identify for the individual what they need to focus in on, and or you can aggregate the results from a team or hospitals or a multi-hospital system and really start to drive education focus. The next example, we're just drilling down and just show you the analytics that are automatically generated as soon as your individual or teams finish assessment. The first graph is assessment 1. It's an average of all clinicians, 1 unit in a facility. The orange box represents the hospital average. The individual green dots represent clinicians. If you look at the right graphic on the scatter plot, you see all of those individual dots are up and to the right and clustered. So really important here, you're seeing improvement from time 1 to time 2, less variation, and in our world, in healthcare, less risk, because OB and emergency medicine are 2 of the primary reasons why where adverse events happen and where claims occur. We also are seeing results. We're seeing a decrease in the cost of claims in organizations that use us by implementing our programs. Like I had mentioned earlier, it's a unique way to learn, assessment-based, and then getting only the content that you need. And organizations are actually returning money back to their organizations around claims exposure because the cost of claims are down. And then on the right, you see clinical outcomes, which is really important. That's why we're doing this to begin with. We want to improve patient outcomes, patient safety. And in this example, we're seeing less massive transfusion protocols, and there's also financial ROI on this. Why focus on emergency medicine? Dr. Binder, tell us a little bit about your experience. What's happening right now?
Well, I think one of the main issues is that there's when malpractice suits are filed, a lot of times it's secondary to a delay in diagnosis. And that's over 50% of the cases. And that sometimes be rectified by getting the team on the same page and narrowing the professional gap between physicians and nurses on certain disease processes and helping improve the system.
And you raise a great point. And Katie, you may want to comment on this as well. I mean, historically, the way that education has been deployed in the emergency department has been completely disparate and separate for what physicians do, what physician assistants do, and what nursing does. Katie, what's been your experience?
Absolutely. I've seen anything from here's your annual packet, fill it out and turn it back in, to nurses going into the break room to take a test and actually cheating. So you just never know.
So we call that cheating and not group thinking, maybe? No, I don't. Yeah, exactly. The next slide really just shows all of the education solutions that we are currently offering in emergency medicine. High-risk abdominal pain, I always call it ABPEL, so I'm trying to get over my own vernacular. But high-risk abdominal pain in the ED, high-risk chest pain in the ED, communication in the ED. Again, this is miscommunication, truncated communication, lapses in what should be communicated. And then, of course, we're going to be talking more about nurse triage in the ED and our newest course, Pediatric Fever Without a Source. That was actually driven out of a large demand from several of our clients. It's a hot button because emergency rooms aren't necessarily, they see everybody, right? And not everybody's an expert in pediatrics. Katie, I'm going to turn it over to you a little bit to just talk about nursing triage and kind of the backdrop to why nursing triage as a first course for Dignity Health.
Well, thank you. I arrived at my position almost 3 years ago, and when I looked at the education that our nurses were getting, it was pretty spotty, and it came from several buckets. And there's nothing more difficult for an educator or even an ER manager without an educator to keep reports and keep track of their staff. And one of the courses that I was particularly concerned about was the nursing triage course. I took the material myself, and I didn't find that it really taught the material as well as it could have. And there wasn't a lot of actual critical thinking and judgment involved in that course. And I then consulted with my perinatal specialist who uses GNOSIS, and she was describing how wonderful the GNOSIS courses were, that they actually tailored learning for the learner, computerized adaptive testing, that modules would appear if the nurses were not doing as well as they could, or if they were doing very, very well in knowledge, judgment, critical thinking, they wouldn't have to do modules. So I asked, is there a triage course? And I was told there is not one currently, but there could be if we partnered. So I did some visiting of all of my departments. I tend to go to 37 ERs about 4 to 5 times a year, sometimes less, sometimes more, depending on how they're doing. And I spoke to the educators and the directors and managers and found that there was just really a lack of good education, that there was, again, that referenced, here's your pile of work to do for the year, or in some cases, they skipped it and had them do a module online. And a nurse could take anywhere from 10 hours to do the module, or if he or she wanted, they could do up to 72. I settled on we need to do something differently. We need to have ease of use, ease of reporting, and also consolidate all of our education into one bucket. You can see we've got 3 states listed here for Dignity Health. We have 40 acute care hospitals, 37 ERs. We see 1.7 million visitors a day, and we have about 3,000 ED RNs, which is a big chunk. Nevada, our service area is concentrated in Las Vegas. Arizona is in Phoenix. But California, we're scattered everywhere. And my office is in San Francisco, but I'm currently in Southern California on a visit today. So busy, busy job. So here is a classic GNOSIS screenshot, and feel free to break in whenever you need to. But this is probably one of the most wonderful things about GNOSIS are the visuals. I took the high-risk chest pain module, and I've never seen a visual that actually corresponded to 12-lead EKG with the plane of the heart, where the EKG was actually measuring variation and ischemia. And it was just eye-opening that we could have those kinds of visuals, measure judgment and knowledge and critical thinking, and get a report all at the same time.
Excellent.
So here is our scatter plot for our nursing triage. We are, so far, I believe, the only ones in this bucket, but I believe the course is being brought to other systems and institutions. So my work—
That's correct. So let me jump in here just for a minute, Katie, just to kind of give the lay of the land to this visual, which is, this is what we call a scatter plot. We measure two primary variables, as you already indicated. On the X and Y axis, you'll notice judgment and knowledge score, and you are correct. So it's about 2,000 Dignity Health nurses that represent, and which is a very large number of nurses. I mean, try to think about the scalability of trying to create an education standard and get everybody on the same page on the evidence-based guidelines for triaging. And e-learning and the assessment-based approach is one of the ways that you do that. But again, because it's assessment-based, you as an ER nurse leader are able to see where your team and individual nurses across your multiple hospitals, your 36 facilities, lie on this graphic. And so this is compared to your own Dignity Health average, just to lay that out. The orange boxes represent all of your facilities. The green dots represent your nurses. And Katie, when you see this graphic, what does it say to you?
That I have some work to do.
Don't we all, right? A big pattern of variation, right? And how does that equate to some of the goals that you're, striving for at Dignity Health around variation?
Well, variation is risk, and standardization, whenever possible, is the goal. And so what I see here is that we do have a ton of variation in how we triage, how well we triage. We did have some legal consultants do a lecture last year on triaging in the state of California, and we were only 54% accurate most of the time. So looking at this, I can tell you that I agree with that statement that we were probably only 54% accurate, and we need some work.
Okay, great. So this next view really quite simply is facilities, showing the functionality of how you're able to drill down and make this hopefully onerous to the local leadership in this one facility. You're able to identify what is the variation within one facility, and when you are in the actual platform and you hover over any particular green dot, which represents an individual clinician, this happens to be nursing, but you could do the same on a provider depending on what the course is. And you can identify, oh, is this a new grad? Is this somebody who just came out of training? Is this a novice nurse? Whatever or is this a 20-year veteran who is a preceptor? We hear that all the time. And again, I'm curious, Katie, what are you hearing from your local leaders on their data?
Well, they're surprised. It's twofold. They're very interested in how they performed, and the providers themselves are surprised that we suddenly have an influx of ESI2 patients, and I reminded them that they'd always been there, that we just now were identifying them better. Classically, a sick patient could possibly come in and get an ESI4 when in reality they needed the resources or the acuity score of a 2. So now I believe that we are doing what we should have always done, is classify them correctly and get them care. So hopefully we've reduced risk quite a bit in that area.
Great. And so what you were speaking to are the practice areas, and that's the next level of reporting that's available, which is by practice area, where's the opportunity to really focus in on the education? And again, so this is based on your average. But for this particular hospital, this is the same one hospital, they are in the 0 to 25th percentile compared to all of the other near 2,000 nurses in the system on Practice Area 1, which is 5 index system. Bill, how does this play out to, what your experience has been?
Well, a lot of nurses don't necessarily know, just the history of the ESI, Emergency Severity Index, and, where it kind of came from, and thus necessarily understand the 5-level triage system. And then many do, and but not always, they might not always know how to accurately use it. And, we've kind of seen that over the years, and I'm still practicing, so I see it at my own shop, unfortunately, and in particular in actually Practice Area 2, which are the pitfalls and barriers to effective and accurate triage. There's a lot of bias in assessment and triage of patients. Older patients that don't always necessarily recognize the severity of their illness, they don't always present typically. And if that's those typical symptoms aren't necessarily on a list of what to look for, one might, clearly miss an NSTEMI or, anything along that lines. And I've seen that, multiple times really in the last couple of weeks. This is part and parcel of what we do.
So in the 5-tier system, I'm just curious, Katie and Bill, what is most often, I guess, incorrectly numbered? Is it a 2 to a 3, a 1 to a 2?
I would say it's the 2 to the 3 and the other direction. The ES or the triage level 3 is definitely the larger sum of all the other triages, but in that ESI 3 group, there are definitely 2s that should have been pulled out. But again, a nurse is very biased. They could say, well, I have a full waiting room and not enough nurses in the back. I can't make 2s. So, that was the experience we were finding before.
Right. Totally agree with you, Kitty. That's exactly, and that's where the literature really shows the greatest amount of confusion is, in the ESI 2 and ESI 3 kind of data.
Interesting. And do nurses and physicians tend to agree or disagree on the triaging? I always think this is a fun question.
I don't know. I'm going to take the fifth, if I may.
No, I think a lot of the time they see different aspects of the patient care issues. I'm a nurse practitioner as well, so I'm going to think in differentials, and I'm going to think like a nurse. And I can see both sides of the coin. Definitely somebody with a lot of care needs is going to feel like a 2, but a provider's going to say, but it's just abdominal pain without any change in vital signs, and things like that. I'll make it a 3. So it could be a little different.
This is what the learning model looks like for Dignity Health. Do you want to walk through where you started in 2016 and what your plan is? You started on nursing triage in the ED, and then what's next?
What's next is pediatric fever of unknown origin, and I was lucky enough to work with Dr. Binder on this topic. It is it's pretty significant in our system. We see a lot of children. We are typically surrounded by tertiary care facilities in Arizona, Nevada, Southern and Northern California. And a lot of the time, that makes our ER nurses, I think, sometimes not as savvy. They don't realize they have the sickest patient in the department when they have a child with a heart rate that is so abnormal, over 200, who needs tons of bolusing. So my goal and my hope is that we can do this class and improve our care at the bedside, because we certainly could use that. And then moving forward, high-risk chest pain and high-risk abdominal pain, I'm hoping to do that in fiscal year 17 and 18. The great thing about these modules is that when you take them, it's not, the time that you take them isn't in infinity. There's actually a counter in the corner, CEUs are given, and a nursing director who's worried about a budget can actually budget in the time pretty successfully and say, I know that it's going to take 2 hours a nurse to do this class because that's how it's numbered, that's how the CEUs are delivered, and I can fairly do that. So it's really great.
Excellent. So the one other thing that we talked about is, so for those individuals, Katie, that score in the lower left quadrant, if you're thinking back to the scatter plot, your intention is to have those individuals potentially, especially those that are in the the 0 to 25th percentile reassess earlier than others.
Yes.
Do you want to talk about that a little bit?
Yeah, so we have identified that there are nurses who did not score as well, and they are in the lower quartile. We are going to look at those nurses and see what level of experience they have. We also have a huge number of nurses that are working in OB/ED, and for those of you who aren't familiar with that kind of unit, we actually have opened up emergency departments that only see our OB patients, and we ran those nurses through the nursing triage course. So we're going to make sure that in that lower quartile, if those nurses are there, we can do some very focused education for that and improve patient care as the outcome.
Excellent. Okay. And then this next graph, really I just wanted to show, and if you have any comments about it, but really it's the number of CME and the average hour it would take to complete an assessment and a learning path. And I actually think we'll go to the next slide, Katie, and you can talk about, what does this mean to you here, which is this is GNOSIS and basically seat time. How much time does it take to complete an assessment? How much time does it take to complete a learning path? And these are actually your system's average time to do that. So we wanted to, get your take on what does this mean to you and to your system.
Well, this is a great way to budget. So, for example, the previous style of learning that we did, it was a little variable. The module could be done in anywhere between 10 and 72 hours. And that simply did not work for a nurse manager director who had productivity issues. This, you can build this in fairly successfully. There's a lot less variability. You know that your nurse is going to take 2.6 hours to do this class. Period, end of statement. It's not going to be 10. It's not going to, So it's just so much more manageable for someone who's concerned about productivity and budget.
Excellent. We have an example that I wanted to share with everybody first. And so Katie and Bill, you guys can comment on this as well. But this is sample content in nurse triage. So Katie, do you want to talk through this, and Bill? The 54-year-old woman reports that she has chest pain that is severe. She states she just recently lost her job and went out last night and had several drinks and woke up this morning and vomited repeatedly. She is uncomfortable. Her BP is 168/92, heart rate 84, and she is afebrile. Above is an immediate ECG. This actually could have come from somebody last night after the election results came in, but that's another topic for another day. So the question is, does this patient have a time-sensitive requirement, and at what triage level should she be designated?
So this is one of the classic questions that is in the nursing triage. It is, I think this is a very different way to do education, because once the nurse chooses an answer, the next answer is reflective on the answer they originally chose and can get more difficult or take them down a different path. So what we're finding here is that this is actually making them think critically and use some judgment. And I've not found that in any other nursing education that I've ever seen.
Okay, great.
Yeah, and just to comment on this, this was actually a case that I saw in the emergency department, and the patient had waited around for probably about 75 minutes or so. She clearly didn't have a STEMI here. She does have an abnormal EKG, however. She waited around, finally got some labs, and her troponin came out positive. It was a Takotsubo myocarditis, cardiomyopathy, and this was, unfortunate case. She did fine, and she went home, not long after, but there's the answer, I think, comes in the back.
Right. So the whole point is that it gives some rationale, right, that's evidence-based as to why, and I think the flow and the staging about how you ought to consider and evaluate this patient, right?
It's real-life triaging. You're triaging that patient.
These people, sometimes, because if you don't see that, if you've got a busy emergency department, for instance, and you see that the ECG is in the STEMI, you might be, more willing, as Katie had said, sometimes when the emergency department's really crowded and you've got these, sick people, how do you ration your care? And you might not call it a ESI level 2, it still is a 2. she just needs to be seen. She actually ended up going to the cath lab, but just later on in the day. But this should have been, needs to be evaluated within 10 minutes. I should have had the CKG, and I, should have, been at the bedside, and I just didn't know.
Exactly. And I think that's one of the other nice, I mean, I'm a clinician by background myself. What's really nice is to learn from real cases, right? These are not created to trip up the user and the learner, but it's really, you're going to see this at some point in time if you have any longevity in the ED, right? You're going to come across these type of patients, and I think these are great learning, I call them narrated simulations. Because they come out of real life. So it's a great case. We have one other example that we wanted to show, and again, this is an 11-year-old boy, has a rash on his forearm. It is itchy, vesicular, I love that word, and linear, and looks like the following. So you have this, really a great visualization of what that is, and then you're just asking a clinician quite simply, select your answer. Katie, I tested Bill on this earlier. What would you rate this as?
I would probably have to look very carefully at the rash, and to me, a rash is, unless it's systemic, it's typically a 5, maybe a 4 if you need to do one resource. But
you got it, Kate.
5.
You got it. It's 5. It's poison ivy. Just had to talk to the kid.
But Katie had also said earlier, I mean, we were talking about the picture, like it's a 5 if it's just localized and it doesn't involve respiratory, right?
Right. There's no systemic, there's no systemic.
Exactly. Exactly. I guess we've gotten a few questions.
Wonderful.
Are there different tracks for doctors and nurses?
This course is primarily for nurses. Physicians can use it, and because I was actually involved with the at the early stages with the ESI, the development of ESI. I worked at Mass General, and we tested it out. It was developed at the Brigham initially, and so physicians had the opportunity to use it, as well as nurses. But this was primarily a course for nurses, and it really depends on the institution and whether they want their physicians to be, kind of aware about some of the issues that nurses face. I think it's actually useful, but can't speak for each institution. All of our other courses generally have, both a nursing track as well as a physician track. This is a little unique.
Yep. And then the other question is, how long should you wait to reassess to show or to measure improvement? And I mean, typically, if you're thinking about adult learning science and our cadence of learning, and in the model that we showed, actually, Tom, if you can go backwards, triage might be slightly unique, but for the majority of our courses, it's a year, every other year reassessment model. And that's different, though, for those that score in the bottom quartile, because they're, obviously indicating that they need to be assessed sooner rather than later because they're not possessing the level of proficiency that you want them to have. We also know, adults don't retain information over the long haul, so that's why it's important to reassess, learn, and then actually provide care and see it in practice, actual practice. And then you apply what you learn in knowledge and judgment during your practice, and then over time you're reassessing again. Anything you would say, Katie, around those two questions that we had and what that means to Dignity Health?
Yeah, I would agree with you that we would probably need to go back and reassess the nurses that scored quite low. But we're going to probably do a pretty deep dive and look at that nurse population by facility. If it's a new grad, that could be something entirely different from someone who, say, has just transferred from the tele floor and has never done triage in his or her life, and they were assigned an ESI course. It was very, very new material. So my thought is that we're going to retest in a year and continue to test every other year for the experienced or intermediate ER nurse. Okay,
perfect. And then the last question really is around why pediatric fever. I know you talked already, Katie, about why it's important to Dignity Health and what your practical experience is, and that you have a lot of variation and comfort and confidence level in how your clinicians are addressing and treating pediatric fever. But Bill, from a national perspective, can you talk about why pediatric fever?
Sure. about 20% of all visits to the emergency department, and there are 140 million visits to emergency departments in the United States, 20% of those are pediatric cases, so it's about 28 million pediatric cases. 90% of pediatric cases are actually not seen in academic pediatric EDs, but are actually seen in the community and, you know, in outlying facilities. And I was actually recently at a conference where we're just discussing even the majority of that group are seen in hospitals where they see generally about 10 to 15 pediatric cases per day. People don't really necessarily gain a great expertise in pediatrics. And so it's really important to, you know, these are very high risk patients. It's a low frequency, but very high risk patients. And you need to kind of get it right, you know, especially in that 0 to 3-year-old population where they can't really chat. Now, there have been recent ACEP guidelines that have come out in dealing with pediatric fever in the 0 to 2-year-old range. So we basically developed this course in concert with Dignity Health, as well as just in also realization that these issues are rather pressing. And ACEP recognized it, and as did we.
Excellent, excellent. Katie, any final comments before we wrap up today's session?
I have been very happy working with GNOSIS. It's a very responsive company. We are looking at different topics to work jointly together. I'm very happy that the nursing triage course is going out nationally. It's Dr. Binder and myself, it's our baby, and we're really excited to see that go where it needs to go. And we're hoping down the line that our patients are the absolute beneficiaries of all this education.
Well, thank you, Katie. Thank you, Bill, for joining us this afternoon. That's the end of the content. For those of you, again, thank you for joining us this afternoon. If you have any questions, we have our website up and our phone number. Again, thanks, everybody. Have a great rest of your afternoon.